Clinical documentation improvement and practice of medicine. A synergistic approach to medicine. This is part 3 in the Clinical Documentation Improvement series, an exclusive presentation from Quantity MD. My name is Glenn Krauss. I'm the Executive Director for the Foundation for Physician Documentation Integrity. Welcome to the presentation. First polling question. Clinical documentation improvement programs primarily exist for the benefit of the hospital. Is that true or false? Well, the answer is false, because clinical documentation improvement programs, they really do benefit the physician, which I'm going to outline very clearly towards the end of this presentation. Stay tuned. Briefly, our objectives are to understand and appreciate the role of clinical documentation improvement specialists in the communication of patient care. Secondly, recognize and understand the constraints and confines that clinical documentation improvement specialists operate within. And third, learn how clinical documentation improvement specialists can be a positive force in your reporting of the practice of medicine. There are many CDI responsibilities, but basically, if we think of clinical documentation, it is the foundation of every health record, and high-quality clinical documentation is the goal of the clinical documentation improvement specialist, in collaboration with physicians in being engaged in the documentation improvement process. The primary responsibilities include reviewing medical records and identifying opportunities for clinical clarification and increased specificity in diagnoses. Now, I'm sure many of you have seen these queries in the chart, asking for clarification about the type of CHF, whether acute or chronic systolic CHF, or is this represent chronic kidney disease stage 3, 4, or 5, and we'll go into how that benefits the physician in a brief bit. How does the query process work? Well, CDI specialists will review the inpatient charts on the floor to identify when a query is appropriate. A query is initiated when the health record documentation is conflicting, imprecise, incomplete, illegible, ambiguous, or inconsistent. When the documentation describes or is associated with clinical indicators without a definitive relationship to underlying diagnosis. For instance, if the white count is elevated as 20 and the patient has bands of 20 and they have a mental status and the patient's on positive inotropes, and the CDI specialist may query for sepsis or septic shock. When the documentation includes clinical indicators, diagnostic evaluations, or no treatment not related to a specific condition or procedure. In other words, physician is treating a clinical condition such as atrial fibrillation, acute renal failure, pre-renal acute renal failure, and there's no diagnosis listed in the chart. When the documentation provides a diagnosis without underlying clinical validation. Or when the documentation is unclear for present on admission indicator assignment. And this is very important because we do not necessarily want to report present on admission indicators for diagnosis that a patient developed in the hospital, such as cubitus ulcer, sepsis, line infection, and so forth. There are certain guidelines that the clinical documentation improvement specialists must follow. And these were outlined and they've been reinforced by the American Health Information Management Association for Clinical Documentation Improvement Specialists practice brief that came out in February of 2013. It was called the Guidelines for Achieving a Compliant Query Process. Let's go through some of the basic guidelines. The foundation for a clinical query is the use of clinical indicators. We must include the clinical indicators identified in the chart that led us to initiate a query. Now, the queries can be multiple choice questions which are preferred, or yes or no questions. Now, the structure and format of answers under the multiple choice and yes and no must include a series of diagnoses plus the opportunity to answer as unable to determine or other, so the physician can outline his thought processes or diagnosis in the chart. Now, yes or no questions are valid or appropriate for present on admission indicators. And these yes and no questions can be used to substantiate or further specify a diagnosis that's already present in the health record. For instance, we have findings in the pathology or radiology or other diagnostic report with interpretation by a physician, such as a stress test or a pathology report with biopsy of a lesion in the stomach or intestine. Coding rules tell us that the physician must actually document the diagnosis in the progress notes and discharge summary. Also, yes and no questions can be used to establish a cause and effect relationship between documented conditions such as manifestations, etiologies, complications, and conditions diagnostic findings. For instance, if the patient has CHF and also hypertension, you may receive a query about whether the CHF is hypertensive related to the hypertension, or if the patient has chronic kidney disease stage 4 and you also have diabetes type 2, Certainly, a more complex patient is portrayed by making that relationship between diabetes and chronic kidney disease, such as diabetic chronic kidney disease stage 3, 4, or 5, or end stage. And also, yes and no questions can be used when resolving conflicting documentation from multiple practitioners. This would be situations such as a hospitalist documenting sepsis and the next hospitalist assuming care the following day might document UTI. Coders are really challenged to validate the diagnosis without a clinical clarification as to which diagnosis is the most appropriate. Now, non-leading queries versus leading queries. This guideline for achieving a compliant query process outlines what constitutes a non-leading query and when and why non-leading queries are not appropriate. Clinical documentation improvement specialists are not permitted to employ leading queries. Why? Because it leaves the physician to a particular answer that may be not clinically relevant, and it's easy for the physician to say yes or no. So a leading query is one that is not supported by the clinical elements in the health record and directs the provider to a specific diagnosis or procedure. I want to give you one example of a leading and contrast that with a non-leading query. And this is a leading query. Hopefully you haven't received any of these from your clinical documentation improvement specialist. Nursing home patient with a history of recurrent pneumonia now with progressive dementia not responding to meds in the outpatient PO world presents to the ER in obtunded state. Elevated WBCs with bands, right lower lobe infiltrate with pneumonia on a chest x-ray interpretation by the radiologist, admitted to a hospital started on IV clindamycin. This would be a leading query. If you ever see one like this in your chart, you know it's a leading query. Does this patient have aspiration pneumonia? Please document it in the record. Well, this is a leading query because it gives you only one choice, and it's easy to say yes or no and move on to the next chart because of the busyness of obviously of the practice of medicine. So this is not permitted by CDI specialists. This is a non-leading query. Nursing home demented patient with frequent recurrent pneumonia presented to the ER yesterday in a totally obtunded state with a white count of 16 with 12 bands. Temperature today taken in the nursing home was 101. Despite 2 doses of antibiotics in the ER, still remained at 101. Chest x-ray read as right lower lobe infiltrate pneumonia. Patient started on clindamycin. Your assessment in the H&P indicates right lower lobe pneumonia. Based on the above clinical scenario, can the etiology of the pneumonia be further specified? If so, please document the type, etiology of the pneumonia in your next progress note and discharge summary to ensure continuity of documentation. Notice this is a non-leading query because there's a diagnosis of pneumonia and the clinical documentation improvement specialist is seeking to clarify whether this represents aspiration pneumonia based on the history of present illness and the other clinical indicators and the fact that the patient's on anaerobic coverage for possible aspiration pneumonia. That's what it appears like in the documentation. Have you ever received a leading query from coders or clinical documentation improvement specialists? Here's what should be done if you do receive a leading query. Obviously, do not answer the query. Bring the leading query concerns to the attention of the HIM director or coding manager if the queries come from a coder or CDI specialist. Bring to the attention of the CDI manager or the CDI director. Clinical clarification and specificity. As I mentioned earlier, CDI programs are not just implemented or carried out for the benefit of the hospital. There is tremendous benefit to the physician in terms of the reporting of the appropriate care and the complexity of the care with specific and effective documentation. What are the physician benefits? Well, there are many. I'm just going to review the top several benefits. The first one is appropriate reporting and reflection of complexity of physician medical decision-making. Medical decision-making is the clinical judgment of the physician and is also defined as the challenges in coming up with a diagnosis and or management plan for the patient. Severity of illness congruent with the intensity of evaluation treatment and documented thought process, the complexity of medical decision-making. Obviously, we have a plan of care that goes with every assessment of a patient. We certainly want to equate that and have a tremendous or effective congruency or accurate congruency with the severity of illness, which is the severity of illness reporting reflected in the acuity of the diagnoses. Obviously, if you write CHF as opposed to acute exacerbation of chronic systolic heart failure, you're actually reporting a chronic stable condition, which obviously would not be a condition that you would necessarily admit a patient for. And if you order an IV Lasix and strict in and outs, you're actually dealing with a complex patient but reporting an illness of a chronic stable condition. Appropriate reporting of risk-adjusted morbidity and mortality. Risk-adjusted morbidity and mortality is very important in this age of quality of care reporting, value-based payment incentives that Medicare is toying with. We want to have the right risk of morbidity and mortality with the right diagnosis of clinical specificity. Inclusion of specific comorbid conditions directly impacting medical management of other primary conditions. Obviously, we want to show the complexity of the case because not every patient is as sick as others. And if you're having a patient who is very sick with his extended length of stay, we want to have the comorbid conditions that are impacting the management and extending the length of stay, such as chronic kidney disease stage 3 or 4 or 5 with a patient who you're managing with a acute exacerbation of CHF. Obviously, the length of stay is going to be a little bit longer because of the precarious situation of drying out the patient, but not drying out to the patient to the extent that they go into acute renal failure. A few extra physician benefits are accurate reporting of your clinical judgment, proper reflection of evidence-based medical decision-making. You're following the standards of care with your orders that coincide with the specificity of diagnosis. And really important is the appropriate demonstration of medical necessity for the patient encounter. Medical necessity is not only a hospital initiative. Every service provided and or ordered by a physician, including E&Ms in the office and the hospital setting, must demonstrate medical necessity, which comes from your specificity of diagnosis and your plan of care, congruent with the patient's presentation of history of present illness. So really, in summary, this is a win-win situation. And in your practice of medicine, if you practice in the hospital setting, please support and embrace clinical documentation improvement initiatives. There's tremendous benefit, as I just outlined, for your reporting of the complexity of the practice of medicine. This ends part 3 of the series of clinical documentation improvement. Thank you for attending.
Please rate this material. Refer it to your colleagues.